And now it's the time to welcome our third eminent professor today, Professor Jorge Hidalgo, Hidalgo. Professor Korg will take us through thromboembolic disease in pregnancy. In brief, Professor Hidalgo is a professor of critical care medicine, Secretary General of the World Federation of Intensive Care and the Critical Care Medicine. He is the head of the Intensive Care Unit and COVID-19 Unit, Belize Healthcare, and a lot of other very eminent titles. Professor Hidalgo, please go ahead.
No, first of all, thank you for having me again. It's a pleasure to be with you guys. And also, I enjoy the previous lectures of Dr. Elkholy and also from Dr. Joel and excellent presentations. And of course, I will try to be at the level of the previous presenters. But thank you also for putting this course together and also for the enthusiasm of continual medical education that is those days definitely needed. No, and saying that, I will share my screen and congratulate Dr. Saad and his team for this enthusiasm, trying to get everybody together and share knowledge. You know, I believe every day is a good moment to learn. And as I usually say, the only thing constant in medicine is the change. I mean that whatever we say today, that is the rule or what is the evidence, tomorrow probably with based on the information, on the latest information, we would probably say that things are changing. I mean that's why I'm saying the only thing constant in medicine is the change, and it's always we need to always be open to learn because especially in medicine we don't know everything, and I believe it's always a good opportunity to call for someone to call for assistance in situations when we believe we are on the top of our efforts to help someone. At the end of the day, our main effort is to for our patients. No, we that's why we are in this continuous effort to trying to offer to our patients the best opportunity we have. And that's saying that what we are going to try to cover in the following minutes is the thromboembolic disease during pregnancy. And then the main idea is to essentially recognize what are the risk factors as well as the pathophysiological events that lead to the diagnosis of the thromboembolic events during pregnancy. And also we will try to review the different options that we have as a diagnostic tool for patients with thromboembolism, especially in pregnancy. And we'll cover some of the aspects of the thromboprophylaxis during pregnancy, because at the end of the day, I believe that that's the key. I mean that's the common reason why we get called and is to see a patient, like in this case, a 30-year-old obese pregnant patient that was rushed to the emergency room with 37-week gestation, complaining of shortness of breath for the past few hours, with a history of 3 previous pregnancies that were uncomplicated. And when we assess her, we see that the vital signs patient is presenting with a heart rate of 120 per minute, respiratory rate 38 breaths per minute, and saturation at 90% at room air. I mean that the first thing we need to address is what are the more likely diagnoses for these patient symptoms? And the second is how we are going to approach this patient initially. You know, those are the questions that we probably at the beginning we have. And saying that just as a context, we say that in terms of the epidemiology of the thromboembolic disease during pregnancy, and we have some data from the Center for Disease Control and National Pregnancy Register Surveillance data collected from 1991 to 1999. We see that pulmonary embolism was the leading cause of maternal mortality. And in this study, more or less on from 4,200 pregnancy-related deaths reported in the US at that point, during that period of time, 20% of the maternal deaths was attributed to pulmonary embolism. And at that point, these events were essentially surpassing pregnancy-related hypertensive disorders, postpartum hemorrhage, and infections. And then in other data from 2011 and 2012, as well from the National Pregnancy Registry, 9% of the maternal less pregnancy-related was also attributed to thromboembolic events. But also getting information from other areas of the world, and we have the United Kingdom Center for Maternal and Child Inquiries, and we see in this 8th report, and then they say that thromboembolic events was the leading cause of direct maternal death in the period of 1985 to 2008, and more common than sepsis, preeclampsia, agnostic fluid embolism, hemorrhage. And however, interestingly, after that, from 2006 and 2008, after the Royal College of Obstetricians and Gynecologists presented the guideline for thromboprophylaxis during pregnancy, we see an important decrease on the rate of mortality in those patients. I mean that we can say that the pregnancy increases the risk of thromboembolic events for an average of 4 to 5 times over the non-pregnant state. No? And overall, the prevalence of VTE in pregnancy is 0.5 to 2 per 1,000 pregnancy, and accounts for 1.1 deaths in 100,000 pregnancies, and an average of 75 to 80% embolic events in pregnancy. You know, I mean that those used to share and to present what the data we have so far. No? And of course, the most the common forms of events are deep venous thrombosis, pulmonary embolism, that essentially we are going to be focused in the rest of the presentation, but we have also septic pelvic thrombophlebitis, ovarian vein thrombosis as some of the events. No? And thromboembolic disease, of course, is the major contributor to both perinatal and maternal morbidity and mortality worldwide. No? And the World Health Organization estimates that represents an average of 3.2 of the maternal deaths between the years of 2003 and 2012. Definitely, the most data from the national inpatient sample indicate that the rates of DVT and PE are currently 0.4 and 0.2 per 1,000 delivery hospitalizations. mean that definitely BTE is an important event, and we need to be trying to see what things needs to be done in order for us to reduce those numbers. No? And the cornerstone of the BTE management lies in an ongoing systems-based strategies for prevention. And of course, as in every situation, we need to have a high index of suspicions and definitely a very prompt treatment. Then the physiological changes of that we see in those patients, and then we'll see an important physiological changes that essentially it will occur during pregnancy, and some of them are procoagulant factors like fibrinogen, factor 1, no? Factor 7, factor 8, and factor 10. And also we'll see von Willebrand factor, those are going to increase. Also we'll see plasminogen activator, inhibitor 1 and 2 that also are going to be high. The fibrinolytic activity is going to be reduced. And also we'll see a reduction in the protein S and protein C levels. And the venous flow is going to be reduced. And those changes begin with conception and probably may persist for up to 12 weeks postpartum. As a result of the physiological changes, also the events, thrombotic events occurs in a rate, as we mentioned already, 4 times higher compared with patients that are in non-pregnant state. No? The postpartum period is probably also more thrombogenic with thromboembolic based TIAs like as probably a given 6-week period during pregnancy. Then the BTEs basically not occur more remarkable, but of course those systems or those different events are going to slowly go back to normal in the post-period part. No? Mean that given the paradoxical challenges presented to the hemostasis during pregnancy, despite of that, I don't think so. We've seen so much problems that we should, if we follow those pathophysiological events. Now, the most profound hemostatic challenges is faced by mothers during the first third stage of labor, following the separation of the placenta for the uterine wall after a delivery of the infant. The hemostasis must be rapidly achieved, basically remodeling the spiral arteries to avoid potential catastrophic hemorrhage. And of course, when we have some local factors, tal of the decidual tissue factor, and the expression of other different elements that definitely are trying to contain hemostatic challenges. No? And of course, in addition to innate hypercoagulability and venous ectasis and vascular thrombo, that essentially it will say that complete the famous virtual classic trial that is basically passed over the years and is something that we are still using to understand the different phenomena in this type of patients. No, this is the cascade of coagulation. We are not going to detain too much on that. I just want for you to excuse me for 1 minute. I need to take an emergency call. Then the cascade of coagulation, and then as we already mentioned, pregnancy is classically thought that essentially be an hypercoagulable state, you know, and the virtual triad, as we know already, venous ectasis, the endothelial lesion, and the different hypercoagulable phenomenons, you know, mean that those are definitely important. And then this is the virtual triad that we know, and this is essentially a virtual trying to be adapted for this particular group of patients, and we see compression of the iliac veins, the right iliac artery over the left iliac vein, the gravid uterus, hormonally mediated vein dilation and immobilization to explain the ecstasis. And then the vascular damage, vascular compression and delivery, assisted or operative delivery, and hypercoagulant situations, procoagulant factors, fibrinogen that is increased, factor 5, 9, 10, and 12, and 8, the anticoagulant activity, especially deficiencies of protein S levels, increase on activated protein C resistant, and then also fibrinolytic activity, those for the hypercoagulant form that basically compounding the famous virtue try that we know and been reading over the years in medical school, and the application of that for this particular group of patients. No, I mean that in a review of the international classification of disease codes from probably 9 million pregnancy admissions and over 73,000 postpartum admissions in the United States, a list of medical and obstetric risk factors for VTE were identified. And then we see that the most important risk factor for VTE are a personal history of thrombosis and the presence of inherited or acquired thrombophilia. And the most important risk factor for a woman experiencing pregnancy-related VTE is a prior personal history of VTE, which increases his chances of clotting for, as we mentioned, 3 to 5 times more. The next common risk factor are thrombophilia, which is present in 20 to 50 of women with VTE in pregnancy. And other common risk factors include C-section, which conveys twice or risk factor the VTE as vaginal delivery, obesity, maternal cardiac diseases, premature delivery, and smoking. No? We're trying to summarize in this slide the different elements of factors: cesarean delivery, prolonged immobility, postpartum hemorrhage, preeclampsia, obesity, tobacco, abuse, age more than 25 years old, pregnancy achieved through assisted reproduction, black race, heart disease, sickle cells, diabetes mellitus, and multiple pregnancy. I mean those are also some of the other medical conditions and risk factors related to VTE. As we can see, thrombophilia, history of thrombosis, antiphospholipid syndrome, other list of conditions that we discussed, and obstetric conditions that could be transfusion, electrolyte imbalance, postpartum infection, anemia, hyperemesis, antepartum hemorrhage, and as you can see, other in the list, mean that we need to have a high index of suspicions and also be always vigilant for all these different conditions that we need to have into account. And of course, after that, we need to try to collect some score and trying to put those on perspective to see who is going to be more prone to develop complications than other ones. And thrombophilia, as we know, probably one of the most common are factor V latent and protein mutation as one of the most common one. And of course, we have several other elements that we need to have in consideration. As many as half of the VTE events during pregnancy occur in women with a pre-existing thrombophilia. And these thrombophilic states can be divided into that we know that could be inheritable thrombophilia, and the most significant, as we already mentioned, is the factor V latent and the prothrombin gene mutations, no, are the common ones. And we have the acquired thrombophilia, and the most common acquired thrombophilia is the antiphospholipid syndrome, In an average, 2% of these patients will experience VTE in pregnancy, accounting for approximately 1,400 VTE events during pregnancy. Mean that we need to have an important index of suspicion, especially when we are trying to make the diagnosis of antiphospholipid syndrome. No? And here is, I'm not going to go into the details, but some of the clinical criteria, some of the non-obstetric and obstetric clinical data that we need to have into account, and also the clinical history along with the supported by the laboratory criteria to make the diagnosis of an antiphospholipid antibody syndrome as one of the acquired thrombophilias that we need to have in mind in this group of patients. The DVT characteristic score, then we also have to have it in mind. If a patient is a patient with history of cancer, immobilization for other reasons, bed rest, local tenderness, swelling in the legs, pitting edema, among other things. And the Wells criteria that we use for pulmonary embolism, suspected DVT, alternative diagnosis less likely than PE, heart rate more than 100 per minute, an important prior history of VTE, immobilizations, active malignancy, and hemoptysis. And also some other elements that we can use, the PERC rule with low clinical probability, heart rate, pulse oximetry, no hemoptysis, no previous events, no surgery, some other elements that we can use to rule out pulmonary embolism. And the simplified revised Geneva score for PE also then gives some additional data or some different criteria for this particular group of patients, and also the clinical probability depends on the score. Meaning that based on that, then we can say we can score right here, and also we can address the different thromboprophylaxis events based on the possibility of someone to potentially develop a complication or go to pulmonary or embolism or deep venous thrombosis in this particular group of patients. I mean, the diagnosis is important, as we always say and emphasize. Having clinical data is important. Signs and symptoms of VTE are definitely non-specific and common in pregnancy. Majority of pregnant women experience mild tachycardia, tachypnea, dyspnea, and lower extremity edema. Diagnosis of VTE by physical examination is sometimes could be inaccurate, but we need to definitely have in mind. The clinical suspicion is important, and then DVT can appear as pain in the inguinal area, abdomen, lower back, and then we need to essentially see the left rule, validation, left leg, edema, presentation in the first trimester. Now, the most common symptoms of DVT definitely are pain and swelling in the lower leg. 80% of the women with DVT experience those symptoms, although few of them are diagnosed with DVT. Up to 70% of women experience dyspnea in pregnancy, although only few have a pulmonary embolism. I mean, that those are important, that we need to have in consideration. We know that the clinical signs and symptoms are not specific. The classic symptoms, as we know, dyspnea in probably 82%, the sudden chest pain, 49%, the presence of cough, and the most common presenting signs and symptoms that could be tachypnea, crackles, tachycardia, just to mention that now, all of these signs and symptoms of PE are only rarely encountered together. We would like to have something like in the book, but sometimes And that's why we are getting consultant for patients that are challenged. The symptoms and signs are also commonly found in pregnant patients. And then most of the times we are essentially in contact with a very difficult uh, patient to diagnose. Meaning that's why we need to have a high index of suspicions and trying to collect data as much as possible to be able to make the diagnosis. One of the things also is important is D-dimer. D-dimer, of course, is often used in non-pregnant patients due to its high negative predictive value, but D-dimer increases progressively through gestation, adding to the difficulty in selecting an appropriate cutoff value for reasonable specific in pregnancy. High negative predictive value of D-dimer in DVT pregnancy has also been demonstrated prospectively, mean that is definitely the utility of D-dimer is something that we can use, but we need to rely more in other type of information. The imaging, of course, we use the ultrasound as one of the most, the compression ultrasonography as a non-invasive is probably one of the most important tests for the lower extremity that we can use. It's been shown that more than 90% sensitivity and specificity for proximal lower extremity, mean that it's very valuable right now in the era of the ultrasound, and especially in the ICU. The ultrasound at the bedside is a tool that definitely is growing. We're using it more and more every day. It's a tool that is not invasive and can be easily applied in patients, especially at the bedside. Then one more time, we emphasize essentially in the data in clinical diagnosis and other symptoms, compare and we correlate with the findings in the ultrasonography to confirm diagnosis of pulmonary events. Another important aspect is that the imaging for either DVT and PE are the best methods to screen and to evaluate those issues. But of course, some others like the spiral CT or pulmonary angiography and the ventilation perfusion, the scanning is of course something that we can use. The ventilation perfusion scanning expose the fetus or mother to ionizing radiation, or this potential risk must be compared to up to 30% mortality in patients with PE left undiagnosed and untreated. Mean that those days, of course, with the use of the CAT scan, will less and less use either angiography or the BQ test. Of course, is always a patient that is going to be presented with challenge to diagnose, and that we need to have an additional tools to confirm or to rule out the diagnosis. The CT, the CAT scan definitely, the contrasted CAT scan definitely is something that is being used more and more with a specificity of 90%, can help in finding alternative pathologies to pulmonary thromboembolism. This radiation is delivered to fetus, but no for the mother. And MRI is also that is being also in trials. We see what should be the utility of the MRI for diagnosis of pulmonary embolism in the future. This is more or less an algorithm. I'm not going to stop too much or spend too much time in this algorithm. Is difficult to read in a slide. Echocardiography is also a tool that it helps us a lot at the bedside of the patient. Essentially, what we are looking for right ventricular dysfunction and strain, tricuspid insufficiency, paradoxical septal motion, maybe early signs of impeding hemodynamically instability and need for thrombolytic therapy. In that, based on that, then the most important tool, so the most important approach is to prevent. In that case, we use some prophylaxis recommendation at delivery, post-cesarean delivery, patient with a previous DVT and thrombophilia without previous DVT, delivery following uncomplicated vaginal delivery in absence of risk factor, generally is not indicated, C-section, obesity, then those are additional risk, and we need to consider in that case the use of prophylaxis. Early mobilization and avoiding dehydration are key and important, and low molecular weight heparin is preferred to the unfractionated heparin that are basically the two both medication that most of the time will be used. Post-cesarean delivery, either unfractionated heparin or low molecular weight can be used with sequential compression devices. The timing of the first dose depends on whether the postpartum hemorrhage occurred or whether regional or general anesthesia was used. I mean that we need to make that decision, or we need to make that call. And for high-risk patients, extended prophylaxis, probably up to 4 to 6 weeks, are indicated, and is something that we need to have in mind at the moment of discharging a patient. Patient with previous DVT, then we need definitely use prophylaxis either with unfractionated heparin or low molecular weight heparin. Vitamin K antagonists can cause fetal hazard and should be avoided before delivery. With high level of suspicion exists for pulmonary embolism, empiric anticoagulation is recommended unless we find any contraindication for other reasons prior to the diagnosis or evaluation. And in patients with low or intermediate suspicions of PE or DVT, anticoagulation probably may wait until more conclusive and more additional tests are done. Once the diagnosis of VT is made, then we need to definitely start with therapeutic anticoagulation unless we have any contraindication. Delivery in fully anticoagulant patient must be interrupted at least, especially low molecular weight heparin, must be interrupted at least 12 hours before epidural analgesia. If delivery is planned, scheduled, we definitely have a transition from unfractionated heparin ahead of delivery to simplify anticoagulation management and monitoring. Anticoagulation can be resumed between 12 to 24 hours after epidural catheter removal. And that's some of the important aspects that we need to have in mind. Prophylaxis recommendation, we already discussed. The patient with previous DVT, antepartum, either conservative management if it's provoked, thrombophilia, antepartum thromboprophylaxis definitely is recommended. In the postpartum, also we need to have that in consideration. History of recent DVT, thrombophilia without previous DVT, observational generally recommended rather than treatment. Thrombolytic therapy is also something that we need to have in consideration in hemodynamically unstable patients with refractory hypoxemia. Alteplase is, of course, the drug of the choice. Streptokinase is something that can be used in other areas where alteplases are not available. No? And of course, we need to have a discussion for vena cava filters, especially in non-pregnant patients. I mean that is the definition for massive pulmonary embolism, acute and submassive pulmonary embolism, and low-risk pulmonary embolism. No, I'm not going to stop that, but just to have a consideration in mind in case that decisions need to be made, particularly when we are deciding or not to go for a thrombolysis. mean that this is the end of my presentation, but I just want to finish with a few key points. The pregnancy and the postpartum period are associated with an increased risk of DVT and PE. Clinical signs and symptoms of DVT and PE are frequently unreliable, and we as a clinician must have and maintain high index of suspicions. Treatment with heparin or low molecular weight heparin is a standard during the antepartum period and should be prompt and should continue for a total of 12 to 12 weeks in case a patient needed, depends on the individual risk factor. I mean that each patient needs to be considered as an individual, depends on the risk factor that we already discussed. And in patients with suspected of VTE, the first diagnostic study should be a bilateral ultrasound of the lower extremities. Prophylaxis during antepartum and postpartum period should be considered in patients without VTE who are at risk for developing VTE, and routine screen for inherited thrombophilia is not recommended because, of course, the different tests are very expensive. Saying that, I just want to invite you guys for the World Congress of Intensive Care and Critical Care that is going to be done in Vancouver, Canada, but of course, is going to do via virtual access. No? Everybody invited to participate. Thank you.
Thank you very much, Professor Hidalgo, for this excellent presentation. Actually, you took us as pregnancy and postpartum are commonly associated with thromboembolism, and the incidence is 4 to 5 times greater than non-pregnant, as you mentioned. And you repeatedly said that the high incidence of suspicion is a cornerstone and is a key to detect early and to manage and to give the prophylaxis for pregnant females. We went through the risk factors with the cesarean section, prolonged immobilization, postpartum hemorrhage, and other risk factors. Again, thrombophilia, history of thrombosis, antiphospholipid. And the most important is the risk factor score, that we get a score +1 for active cancer, immobilization, and others. Then you took us through the diagnosis, maybe the most important part with the diagnosis of DVT, the diagnosis of pulmonary embolism, which all starts with the clinical, again, suspicion, high index of suspicion, pain, swelling of lower limb and the left leg, edema, and first trimester, the labs, the imaging with the previous clinical parameters, the D-dimer, the bilateral ultrasonography for both lower limbs, and for the pulmonary embolism diagnosis with the VQ, ventilation, perfusion, scintigraphy, and scanning, pulmonary angiogram with the risk of irradiation to the fetus, with the CT scan with the lower irradiation, MRI, and the probable role in diagnosing the pulmonary embolism, echocardiography. Lastly, you took us through the prophylaxis and the treatment and giving epidural anesthesia or analgesia for delivery in fully anticoagulated patient, which is not an easy scenario. Many of us went through actually, and how to stop the anticoagulant 12 hours before epidural anesthesia and to resume it 12 hours after removal of the catheter. Actually, I thank you very, very much. I find it very beneficial and very important topic that we all get benefit of. Now I have questions to Dr. Nisreen, Professor Dr. Nisreen now. Want to say that general anesthesia is better and superior to regional anesthesia in spinal cord injury, Dr. Nisreen?
Sorry?
I want to say that general anesthesia is superior or is better than regional anesthesia in spinal cord injury, please.
Actually, as I said, we have to weigh the risk against benefit. So in my patient, for example, she didn't have cervical fixation. So and she was slim. So it was easy to intubate her. And psychologically, I couldn't discuss anything. So I just went to general anesthesia and gave her analgesia, and everything went well. If she was obese, for example, with short neck and cervical fixation and difficult intubation, and I have to do awake fiber optic, as Dr. Doyle said, maybe at this time I have to consider the patient, if she will be cooperative and I can intubate awake intubation, or is she easy to ventilate, which is very important. If she's easy to ventilate, and they can give her Deprivan, muscle relaxant, and maintain oxygenation, and put a supraglottic device, and then intubate with fiber optic through the supraglottic device, I will choose this.
Thank you, Dr. Nisreen. Another question to you again about if there is history of brain tumor that was excised less than 1 year ago. Do you prefer regional or general in that case?
Neurologically, that's a good question, because I have another lecture about brain tumors and brain occupying lesions for pregnant women, including idiopathic increased intracranial pressure. In brain occupying lesions, we can't give spinal or regional at all, because there is risk of loss of a few drops of CSF, and then the brain occupying lesion, the tumor um, will collapse down.
Pressure will increase and deconization, that's what you mean, Professor?
Yeah, conization. In idiopathic increased cranial pressure, it's safe to give spinal. So if patient have excised tumor 1 year ago, I have to reassess by her neurologist, do MRI, and be sure that she doesn't have any metastasis or any residual lesion. And if she's fine, I can choose either spinal, epidural, general, doesn't make a difference. But I have to take history, assess the patient neurologically, and sometimes after brain tumors, surgeries, they may have focus of epilepsy or epileptic fits. So I have to detect, is it controlled or uncontrolled, and the cause of epilepsy. Okay.
Thank you very much, Professor Nisreen. The question now is to you, Professor George, that says, if the patient is on anticoagulant and scheduled for cesarean section, and suddenly after a stoppage of the anticoagulants 4 hours, delivery became urgent, how to manage? Yani, the anticoagulant was stopped only 4 hours, not 12 hours. And the delivery now.
Well, we have two choices. No, one, of course, if we need to act promptly, then one of the choices is to administer protamine sulfate. No, that will help us to as the antidote for heparin, and then we can proceed. No, of course, we know that in these circumstances is risky, but we need to take that chance.
Would you like to say that general anesthesia could be considered?
Well, of course, normally the approach of this patient is for a multi-professional team. I mean that most of the time we are not as an intensivist and as well as the critical obstetric gynecologist. Most of the time is something that we discuss with the anesthesiologist as well, and then we make the decision in the best interest for the patient. If one, we decide, okay, we will proceed with, in that case, with protamine sulfate because it's urgent. And then also we discuss the different other situations, like the type of anesthesia, and also where this patient is going to be taken after the procedure. Is going to be in the regular recovery room. She is going to be in a high dependency unit, or the patient is going to be transferred to the critical obstetric ICU.
Thank you very much, Professor Hidalgo. Another question to you, please, sir. Can we give fibrinolytic therapy on cardiopulmonary resuscitation if we suspect pulmonary embolism without presence of any document diagnosing pulmonary embolism? Just
well,
suspect pulmonary embolism.
Right. It's a very difficult question because, of course, we know that either streptokinase or alteplase, those are not very, first of all, they are not cheap medication. No? I mean that we need to have all the different elements that it will sustain, or it will essentially justify for us to put on someone with either alteplase or streptokinase. Mean that we don't have to, if we don't have elements enough, I don't think so.
يعني as far as I know that the ALS course recommends when you suspect pulmonary embolism that the cause of arrest, even if you don't have right now a document, something like ultrasonography or VQ mismatch, etc., you go for longer period of resuscitation, not just the 20 to 30 minutes, and you announce to the patient that
45.
starting fibrinolytic therapy if you suspect. Professor Nisreen, please, would you like to add?
Yeah, no, I agree with you. We have to
Thank you.
continue CPR for 45
Longer
minutes.
period. Yes, yes, longer than usual. Yani that's the guidelines of the ALS, Advanced Life Support, from the European Resuscitation Council.